So for this first part of the screencast, the topic to discuss is, as a clinical team leader on your unit, how would you handle a difficult situation with a problem employee? How to handle this situation and some important facts about what is needed to maintain a normal, healthy working environment during this time. I've always been told that there's two sides to every story, so as a clinical team leader, if a problem arose with an employee, I would make sure that I had all my facts straight, that I was getting them from unbiased sources if possible, and then I would pull that employee to the side into an office where it was just the two of us, to not bring attention to the situation. One, so that I'm not embarrassing the employee, as well as it's a private matter, so patients and other employees don't need to know about it. And I would allow the employee to explain what's been going on, maybe give more insight into why they have been causing some disruption on the unit. And then I would kind of point out what they were doing in the eyes of the other employees, and as well as the directors. On page 676 of the text, they talk about different roles and management functionings dealing with problem employees. And one of the big ways to manage a problem situation is to make sure that all written rules and policies are clearly stated. Make sure that the rationale for each policy is laid out in front, and then clearly identify why that policy or that rule was being broken or disrespected, and making sure that everything was being presented in a black and white, right or wrong way, to make sure that there's no room for misjudgment or falsely accusing or misinterpretation of their actions. After doing that, opening lines of communication for that employee to discuss why they think they were or were not disobeying those set rules, and then following the line of punishment as far as depending on what they were being accused of, making sure that the punishment fit the accusation, whether that be time off, that be what's called a PID in some hospitals, where it's just a disciplinary action on their record, or if it's a possible need for termination, and then going from there as needed. For this second part of the video, we are asked to discuss what is meant by the terms quality improvement and healthcare quality. In the text, it says quality improvement is described as a process/model that ensures that quality efforts are ongoing and that quality can always be improved. Healthcare quality is defined by the Institute of Medicine, and it's the degree to which healthcare services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. As far as the national database for the nursing quality indicators, there's specific indicators that help us maintain these levels of quality. There are about 11 of them, including nursing hours per patient day, patient falls with injury, pediatric pain assessments, pressure ulcer prevention, psychiatric sexual assault rates, restraint prevalence, and there's several others. But as far as two that I think I, as a nurse, can make a difference in, one would be the falls prevention, especially as an emergency department nurse that I plan to go into. Falls are big because there's a high influx of patients and usually not enough staff able to cover the needs of each patient. We're not able to pay as much one-on-one attention to the patients as we would like, so making sure that the bed is always in the lowest position, wheels are locked, for high-risk falls patients as well as any altered mental status patients, making sure that the side rails are up. If you have all of them up, it's considered a restraint, so if you think that's necessary, making sure that there's an order in place and talk to the doctor about it, as well as making sure the call light is always within reach. And then if it's a patient that's continually trying to get out of bed and not completely understanding their physical capacity at that time. Implementing a one-to-one sitter, whether that being the nurse and taking a nurse off the floor to provide care for that patient, or if you have extra ancillary staff, either a clinical associate, a nursing assistant that can sit and monitor this patient and prevent any falls. The other one that I think would be very helpful for me to add into my care as a nurse would be the pressure ulcer prevalence. In my time on Nine Mountain ICU, where we had patients with spinal cord injuries and that were unable to turn themselves, or it was very painful to turn themselves, the rate at which a pressure ulcer forms is insane. Within an hour or two, you could have breakdown of the skin, and that introduces a high infection rate, prolongs the need for hospitalization, prolongs the need for certain medications. So as a nurse, making sure that I'm doing thorough head-to-toe assessments, and even though it may be painful and difficult and need extra hands, making sure I'm checking certain pressure points, especially the sacrum and heels, and using the wedges and pillows to offload the pressure, as well as any orthotic boots and any off healing methods to prevent any further breakdown. When talking about these quality indicators, there's an article that was posted in a 2015 edition of a systematic review performed by Beatty, Murphy, Atherton, and Lauder. And after going through some of the ways to collect data for quality assessments and quality improvement surveys, they found that using the right patient experience instruments depends on a balanced consideration of aspects of the utility aided by the matrix. That's kind of a lot of big words, by just making sure you have the right surveys being used and it's targeted to the right population. And then the data required for high-stake purposes requires a high degree of reliability and validity. So making sure that all our documentation is up to date, that we're documenting appropriately, and not trying to falsify anything, not documenting something we haven't done, and it's for the safety of our patients. And while those used for quality improvement may tolerate lower levels of reliability in favor of other aspects of utility, i.e. educational impact and cost and accessibility, in the end, it is extremely beneficial to not only our patients, but also the staff, because many times staffing in the hospitals in general are the ones that take the financial hit for a lot of the decrease in quality provided. So the better quality improvement surveys we have, the better results and the better adjustments we can make to the care to make sure that we are meeting certain quality improvements standards. Thank you.